Good morning, everyone. I'm Becky Blankenberg. I'm the Associate Chair of Education in Pediatrics, and I'm beyond thrilled to introduce Bob Vinci, who's our speaker today. I have personally known Bob for the last 20 years as an incredible mentor, a genuine, dedicated, personal mentor of mine and many, many others here. To tell you a little bit about Dr. Vinci, he was a residency program director for 28 years, which in and of itself is a feat, first at Boston University and then for the Boston Combined Residency Program. He was a fellowship director for Peds Emergency Medicine for 8 years. He was chair of Boston University for 10 years. And now medical students are lucky enough to have him as the assistant dean of advising at Boston University. In his many, many other hats, he has been a national leader in pediatrics, in pediatric education, in innovating. He helped co-develop the health equity rounds that we use here at Stanford and many other institutions across the United States. He's been a lifelong mentor to many. He helped develop the LEAD program, which is a national leadership program through the Association of Pediatric Program Directors, and has really elevated the voice of marginalized educational leaders and learners through the work that he does. The three words that I would use to describe Bob are transformative, and you will hear about the transformative work that he has done in the Workforce Initiative, humble, and he is such a genuine, I guess, forwards and loving mentor that really comes alongside each individual and helps them see the path that they are headed on, and then extends it to be even more impactful to the people that he serves. Personally, Bob, I just want to thank you for 20 plus years of mentoring. And as a thank you to you, as you come on up here, I was hoping that anyone who has ever been mentored by Bob or learned something from Bob could please stand up, because I know his mentees mean so much to him. Aww. And this is only just a handful of And then last but not least, when I asked what he wanted to be known for, he said he has 4 wonderful grandchildren. Let me see if I can get this right.
Yeah.
Nico, Luca, Mari, and Nova.
Yeah.
And he's so in love with his grandkids. And he's somehow, as an amazing father, pediatrician, mentor, really transformative leader in pediatrics, been able to bring all of this together and just such a role model to all of us. So thank you for being here.
Thank you. Well, I do not deserve that introduction. And actually, Becky, I would have thought it was more than 20 years. It just seems like a lot longer. All right, so here's the goal for today. I'm going to present a lot of data, give an update, and even though I'm presenting it, please recognize that this is coming from an enormous group of talented leaders across the country. And I'm honored to give the Kretchmer lecture. Dr. Kretchmer and I do share one thing in common. We're both born in Brooklyn, New York. Although the hospital I was born in doesn't exist anymore, I think it's now a condo. I want to give special thanks to Dr. Leonard and Dr. Blankenberg for inviting me here. And you will also see they get special thanks because they are part of the team that is working on this workforce initiative. And yesterday I had an opportunity to spend a day with many of the faculty, and I have another date today. And I'm going to intersperse what I've learned from the talented faculty here, because I think there are messages that we need to incorporate into this workforce initiative. The other thing I would say is I want you to suspend disbelief. At least when I listen to Grand Rounds, I think I'm gathering information and just accepting everything. I think the collective we, I know Mary and Becky would say the same thing. We want your input about this initiative. Are we heading in the right direction? So feel free to suspend disbelief, to challenge us to the way we're thinking about this. And you'll see I'm going to incorporate some of the things that I learned yesterday into this talk. So I only have one disclosure, which I'm not going to talk about anything from the Board of Peds, but they ask us to disclose. So I am on the Board of Directors for the Board of Pediatrics. So why are we interested in this topic? I'm not sure if people saw this piece in JAMA that Katie Jordan wrote, and it was basically a perspective on where are all the pediatricians. And I think it's hard not to recognize the impact of last year's pediatric match. And was there a message to us in child health that there is movement away from pediatrics towards other disciplines? And Katie, in this perspective, really described the impact of the match and went on to think about what some of the challenges were. And Sally Permar, who's the chair at Cornell and part of our workforce initiative, and I wrote this quick piece for Stat News, which if you want to get something picked up by the public, it's a pretty good way to get some of the work that you're doing. And I wanted to talk about what we thought. And I think even after yesterday's conversation with many of the faculty, that we may rethink this. But we put in this article that one of the challenges that we don't spend enough time thinking about is what is the value of taking care of children? If you look now at where healthcare expenditures go, it's just disproportionately all to adults. And it's disproportionately to adults my age. I'm going to be 70 next month, and I'm grateful that there's attention to the geriatric population. Sad to say I'm a member of the geriatric population, but I'm going to get over that one of these days. But how many Americans over the age of 65 are there? There's not a quiz, just throw out a figure. 70 million. 58 million. How many kids under the age of 18? 73 million. No one thinks about that. Like when you think about the cost for healthcare, and that's what Sally and I tried to write in this piece, that a fair bit of what's going on with pediatrics is the economics of peds. And we're going to talk and intersperse today some of the ways that we think we're challenged because of the disproportionate number of children who are on Medicaid. And Jim Perrin wrote this. If you haven't seen this perspective in the New England Journal, it is worth reading because what Dr. Perrin called out is basically the way that we have allowed Medicaid to exist is creating inequities in healthcare. Medicaid pays less than Medicare for the same service for a child versus an adult. Medicaid is a state-run or state entitlement. It does receive federal funding, but much of it is administered by each individual state. And because of that, children who are on Medicaid have less access to care. That was proven when the Affordable Care Act was in effect. There were 2 years where Medicaid and Medicare paid the same. And children during those 2 years had more access to pediatricians. Now, that's a sad commentary that it took equalizing Medicaid to Medicare payments to get more access for children. But when it wasn't reauthorized, kids lost access. And that's the point that Dr. Perrin is making in this perspective. And to bring that home, here's the Medicaid to Medicare fee schedule. This is tracked by the Kaiser Family Foundation. Anybody want to tell me where California lands on this, other than Dr. Leonard, who I know knows this off the top of her head? About 40. So I think California is about 72 cents to the dollar for Medicare, which makes it one of the least one of the states most impacted by the differential payments between Medicare and Medicaid. We've been spending a lot of time thinking about the economics of this, and I actually want to challenge all of us to think differently, myself included, because we've spent a lot of time worrying about the money, but I was energized by this dinner that I had last night that we'll talk about. So what do we hope to do today? So with this background, I want to describe some of the concerns about the pediatric workforce data, talk a little bit about a report that we commissioned from the National Academies of Sciences, Engineering, and Medicine, summarize, and this is where you come in because we want you to pull it apart, the workforce initiative and what our current goals are and where we think we're going, and then gather input from each of you here. So I'm going to show a little bit of data, and it'll be a pretty quick data review. So this is what got us started on this work. The reason we have data on the MD graduates is that until recently, the NRMP didn't report as much data on the graduates of the osteopathic medical schools. But if you graph the osteopathic medical schools, the curve is the same. So this is the percentage of MD graduates entering pediatrics over this 15-year period. And you can see the direction of the curve. Now, it looks worrisome, and it is something that we definitely want to pay attention to. Where were we 10 years ago? 10 years ago, I have to stand by the mic, right, so people can hear me. 10 years ago, we had very few spots open in pediatrics after the match. I say that because this curve worries us a lot. But 10 years ago, we had a different worry. 10 years ago, we were worried that we couldn't get our senior graduates into pediatric programs. So that's our first message. I don't want us to think that we have some historic catastrophe occurring in peds. We have a challenge, and we're going to solve it here today by 9 o'clock. Here's the applicant's data. Also, the other message I would give you pretty quickly is be careful how you interpret data. These data sources come from slightly different sources. That first slide comes from the NRMP data set. This comes from ERIS, the AAMC Medical School Application Service. They do a cut every year of how many students have applied to its discipline. And you can see the fall off in MD graduates, the decline in graduates who are international medical grads, both US and non-US born international medical grads, and an overall increase in the number of applicants from graduates of DO granting medical schools, except for the last year, where there was a decline, and that's represented in the number of individuals who matched into peds this year. So everybody remembers the peds match this year was the worst, shouldn't say worst, was the most complicated match because there were so many open slots after the primary match, somewhere around 250 open slots. 10 years ago, we had 10 open slots each year. So things have changed, and I think that's what we want to talk about is what has changed and what can we think about this. Now, this is the starting point. One of the things that worries us is the end point. This is the data on the number of applicants per position for each of the pediatric specialties. And let's see, do I have an arrow? Yeah. So if you look here, it goes backwards, huh? Going to be directionally challenged, but if you look at the area in the red circle, every discipline except one had fewer applicants per position in 2024 compared to 2023. And it led to a complicated subspecialty match. Disciplines that routinely filled all of their positions. We've always had a number of fellowships, and we've grouped them in a way here that you can see the fellowships that are less likely to fill, from adolescent medicine down to infectious disease, they all have less than 0.9 applicants per position. So I did start off as a math major. Even I remember this math, right? So there's no way that you're going to fill when you don't have enough applicants per position. We have to ask ourselves, why is that happening? Because there's such extraordinary work happening in peds. So one of the things is that we don't have somebody advocating for us. This is a magazine cover from 1970, and Growing Old in America, the Unwanted Generation. Who thinks in 2024 they're the unwanted generation based on what you hear? All we hear about is we need to think about caring for adults with chronic disease. We need to think, and don't get me wrong, as an adult who's entering those ages, I want us to be thinking about that. But the pendulum has shifted. We also have the AARP. So when you turn, I don't know, 45 or 50, you get hounded by the AARP to join this organization. We need to figure out what the pediatric equivalent of this is, because really this other magazine cover, I think, speaks the story of what I hope we will talk about today is not who speaks for kids, but how can we better speak for kids? And I think that's the challenge to all of us in this room. And I should have acknowledged everybody on Zoom as well. So what did we do about this? So 4 years ago, the crossout is intentional. I'll explain it in a second. We started this workforce initiative that we named Pediatrics 2025, the Pediatric Workforce Initiative. I was the chair at BU at that time and part of AMSPDC, and we decided amongst AMSPDC leaders that we would take this on. And we said, we could probably do it in 3 years, but let's give ourselves 5 years. Well, it's now 4.5 years later, and we're no closer to the solutions that we need to be. And so we've renamed our initiative, dropped 20 to 25. I made to do this work until, I guess, I finished my geriatric ages, whenever that is. And you can see the goal. The goal that we set in 2020 was to really think about how do we increase the number and diversity of high quality students who enter into all of our training programs, and then subsequently fill the subspecialty workforce. So who's the we? The we is this important group of leaders. This is the group that started this work. I want to acknowledge Laura Degnan, who is the co-leader with me. Laura is an executive director of a few of our national pediatric organizations. But you can see the important contributions that Dr. Leonard made. We also had 4 domain leads. Dr. Blankenberg was one of the leaders of the domain in education. And we have built a coalition of all of the major pediatric organizations to participate in this work. Built a coalition might be too strong of a word. I think we're still working a little bit too much in parallel than we need to be. And so one of our challenges, how do we take this group of about 20 to 25 organizations and have all of us work together? So what I want to discuss today, I want to discuss why should we invest in peds? What can we learn from our trainees? I'm excited there are many trainees here, so I'm hoping you'll give us input. We've talked about the NASM report, and I'll mention the specifics and the direction of our workforce initiative. So why should we invest in peds? I think there's no doubt that kids are our future. I was talking to Paul Wise last night, and I said, Paul, do you think the data is strong enough that this first point is accurate? That if we invest in children's health, that we will prevent the adult diseases that have now shifted the curve to healthcare expenditures really marginalizing kids because they're prioritizing, we as a medical establishment are prioritizing where the healthcare costs are. And Paul said, yes, I believe that, but I don't think that's the argument. Where's Paul? Okay. And I think the point that Paul and I were talking about is it's very hard to convince us to invest in something that's going to pay off in 50 years or 60 years. And things are going to change. There are going to be different things that we're going to do that will shift this cost curve much differently than we think about now, whether that's new treatments for obesity or different treatments for chronic disease. So while we believe this to be true, it's a challenge for us to think about whether that should be the message. But clearly, kids face many risks. During COVID, the number of children who live in an impoverished environment increased. We currently have the largest number of children in the United States living in poverty than ever before. And that's something that we can change, and we need to figure out how we can change. We talk a lot about childhood adversity, but it's very clear that we've ignored children. I have a colleague, some of you know him, Patrick Conway, who's a pediatrician who ran CMS, which is the federal system for Medicaid and Medicare. And we went to see him early on in this initiative. And he told me something that I have not forgotten. He said, Bob, you know what the problem is with pediatricians? They don't come to see me. He said, every week, the orthopedic surgeons, the anesthesiologists, and plastic surgeons are in my office talking about what's wrong with their fee schedules. He goes, I never hear from pediatrics. Now, I think he was overstating the fact, but I think it raises the point that we have this shared responsibility of thinking about how we can advocate differently. And the other piece of this is the pediatric specialists. So pediatric specialists have an incredible role in delivering care here and elsewhere. The figure about the number of children who receive care from a pediatric specialist is astounding. Almost 20% of our kids are involved in care from a pediatric specialist, and over a third of children live with at least one chronic health condition. Those numbers are increasing. You know, one of the arguments that we hear is that the birth rate is declining. Therefore, why do we need more pediatricians? Well, the birth rate is only one part of the story. The number of children living with chronic disease, the number of children with preterm birth, those require attention of our pediatric specialists. The other is, we know care is better when you receive care by a pediatric specialist. If you haven't seen this article by Angie Myers, and some of the faculty here were co-authors on this, it is really worth looking at because it tells a very powerful story of what happens when kids receive care by non-pediatric specialists. There's improved outcomes in asthma. There are less complications for children with chronic inflammatory diseases such as SLE. Dr. Leonard has separately written about the impact of children with chronic kidney disease and what happens when they don't live close to a dialysis center and a center that can manage chronic kidney disease. And many patients in this country live in areas where there's poor access to subspecialty care. We actually found some solutions during COVID. Many people love telehealth. How many people wish we would stop telehealth? You're all mixed on telehealth. All right. But during COVID, you know, the federal government dropped a lot of the restrictions on care across state lines, and it improved outcome in some of the rural areas. They've been pulled back a little bit, And so that has brought us back closer to our pre-COVID baseline than we need to be. We talked briefly about equity before, but the other theme that I think we have to think about is access to care. And what are the access issues for us in pediatrics? So this was a study that the Board of Peds did in 2020. And it was a repeat of a study they had done about 15 years earlier. I think it was 2003 was the first study, and I think the data from this 2020 study was in 2019. But basically, there are now 11 pediatric subspecialties that have less than one subspecialist per 100,000 children. Just think about that as a subspecialist. The second is, and I'll show you this in a second, there are a large number of children who live a significant driving distance from a pediatric subspecialist. It's a wide range. The 1 to 39 million is because it depends on the specialty. I think the 39 million is room. Yeah. And that's not surprising because it's on that list of the undersubscribed specialties. And this is work that the AAP has done. This is very powerful work that you can find online. You can, for each state, now look at the driving distance for patients for every pediatric specialty. And this is the California data, which is pretty good, not perfect, but pretty good. But there are some states that, like Wyoming, has no pediatric rheumatologists. And I think very few pediatric gastroenterologists. And it's a lot of ground to cover. And we need to be thinking about that. So we really want to shift gears in the messaging that we're giving to access and equity. At dinner last night, we talked about the economic challenges of peace. And I just want to tell you where we are because I think there are now creative solutions that are being looked at. There are creative solutions that have already been undertaken here under Dr. Leonard's stewardship of this department. This was a study that got everybody alarmed. This is the group of specialists and what's called their lifetime relative net value. It's a corollary for salary support over the course of your career. There are 3 disciplines, cardiology, critical care, and neonatology, who make more than the baseline. The baseline was a community-based general pediatrician. Now, some people have odds with whether that's the right baseline, but you can see the large number of fellowship or subspecialties that have a lower lifetime earning potential, basically, compared to a general pediatrician. Why do we let that happen? Why is it that we ask you to train 3 more years and your long-term revenue potential will be different, if not less, than a general pediatrician? And people looked at, how do we fix this? Do we do loan repayment? Do we shorten fellowships? There's not a lot to shift the curve. What's going to shift the curve is an investment from our health systems to really think about how we do salaries different in pediatrics. But what's equally important and is it seems to be driving the decision of some of our trainees. So this was a study that Colin Orr did to look at, if you have educational debt, are you more likely to choose a fellowship that has a higher net earning potential? And not surprisingly, there's a hint of if you have significant debt, greater than 200,000 to 300,000, the average debt now is around 240,000 for graduates of our medical schools. But there is a shift into the careers that individuals are choosing. The other is a really tough study to read, which is the debt burden of our colleagues who are underrepresented in medicine. And this disparity is something that we have to take on. And when we think in a minute about some of the solutions that we're considering, we need to look at this. A third of our pediatric residents who identify as Black or African American have a debt burden of greater than $300,000. That's an enormous amount of lifetime burden that we're placing on a population that we need in peds, right? We've had minimal success thinking about how we diversify our workforce, no different than many other disciplines. Dr. Blankenberg led for us this incredibly powerful summit where she brought together leaders from the UIM community to help us think about creative solutions to this challenge. So the question then is, do pediatric salaries impact the career choices of students? So what do you do when you have a question you can't answer? You Google it, right? So I Googled it and I found, I think it's called Student Doctor Network. Anybody else? Am I the only one that's actually now connected to Student Doctor Network? All right, well, the title of this was Searching for the Truth About Peds Subspecialty Salaries. And a medical student wrote, "Hi all, M3 ear who's been set on choosing pediatrics since decided to pursue medicine. I've always been interested in pursuing one of the high acuity specialties. And I'm curious about how much these physicians are really making, not because I plan for income to be a deciding factor. Otherwise, I wouldn't go into peds, LOL. So here's the response. There's a huge variation in salaries, even in the same specialty. I'm peds endo. You don't do my specialty unless you love it, because almost universally you make more in gen peds. We're giving out that message. I think what's missing in here is the love it. So I don't want to put Kevin Chi on the spot yesterday, but Kevin and I had this amazing conversation about the joy of pediatrics. And that's a theme that we're going to come back to. None of us choose this because of money. We're all going to be fine. We're going to have to figure out, we can't ignore the economics, but we've got to come back to the things that, why this room is so packed with talented people, is you're going to make a difference in the lives of so many patients. Whether, as Paul Weiss said, that we won't be able to get others to really strongly support that doing that makes we know that doing it makes a difference. Whether that's the only argument we should make is probably where we need to move away from. So I'm here to talk about the joy of peds today. Kevin's going to be our poster person because it was such a phenomenal conversation. And I know one of your chief residents, Chris, who I think may be on Zoom or is interviewing today, has looked at this question. So Chris, if you're on Zoom, please email me because I want to talk to you about your study. But this is another study that looked at what are the factors that influence medical students' careers choice to peds. There's a fair bit of data that says that it hasn't been much about finances. This is a small study. I think it's 7 or 8 medical schools. But what was interesting was, one, the large number of people who considered peds, and 2, that economics drove people away. So while I want to get back to the joy of peds, we're going to work on the economic issue because it's solvable. And I think everyone in this room should feel pretty excited about their future, which is why we asked the National Academies to do this study for us. And the National Academies, if you don't know, used to be called the Institute of Medicine. It's now a larger group of academies in DC. It does report out to Congress, but it is not under congressional control. So it's an independent group. And we asked them to do a study on the pediatric workforce. And they came back to us with, the report's 360 pages, like all of those, but there's a few page executive summary that is really worth reading because it powerfully gives out the messages of the direction we should be going. And this is the direction that we should be going. These are the goals that we heard about. We heard that, hey, peds, wake up. You've got to do more to think about how you help the general pediatrician and how you help the specialist. You don't have to put your hand up, but I suspect there are many specialists here who think that some of the patients you've seen could have been cared for by a generalist. And I think there are many generalists who would say, but the incentives are so complex for us that we don't have the time to do the care that's required. So that's the first theme. The second theme is the economics that we have to work on. The third theme is changing education. I'm part of the problem. I was a program director, as Becky said, for a long number of years in my career. And until recently, we would train everybody the same way. Whether you were going to be a general pediatrician, an intensivist, a researcher, work in public health, it's time that we change that. It's time that we move away from the pathways that we currently have. And the last is the important contributions to the scientific community. So we've just changed our workforce initiative, and I want to tell you quickly about what we're doing. And you can see the new work groups that align with the NASM report. Dr. Leonard, Dr. Blankenberg are two of our leaders. So I have to tell you, when I told this story quickly at dinner last night, when we started this initiative, we were thinking about who has the energy to take on an important problem like the economics of pediatrics. So I emailed Dr. Leonard and said, Mary, how would you think about being the domain leader for the economic strategy group? And she writes back, yes. 4 exclamation points. And then we realized that she and I both had a pretty steep learning curve because this is a very complicated issue. So what are we heading towards? We're heading to this. So these are the things that we're thinking of moving towards. And this is the part where we really want your input. So for the economic strategy, we want to reduce the financial incentives. That's the goal. So we definitely need payment reform. No one's going to argue that we don't need payment reform, but we can't focus only on payment reform. If we do, it'll be a slog for many years. Depending on what happens with this is a very important election. I'm not allowed to tell you who to vote for, but please vote. I'm allowed to say that. Our partnerships are key. We talked yesterday with a number of our groups about building stronger coalitions. The legislative arms of the Children's Hospital Association and the American Academy of Pediatrics are very powerful and can help us think about partnerships so that we can impact Medicaid and how Medicaid is run state by state. We have tracked down the executive director for the state medical directors. That person is going to rue the day they've taken that position because we're going to hound that person to think about how we institutionalize change across the country. The other thing about payment reform is that we should support innovative care models. That question that I said, please don't raise your hand about how many subspecialists think this should have been cared for by a generalist and vice versa. It's because we have malaligned incentives. And we shouldn't think of payment reform only as we got to fix Medicaid. We do need to think about that, but we've got to think about other innovative models. Let's retrain. If we're going to retrain, I'm looking at Dr. Blankenberg because she's leading this domain. Why shouldn't every pediatrician come out with a special skill? I know ADHD really well. I know asthma really well. So that when you join different practices, you become the local expert. And it's a way to decrease the burden on the specialists. It's a way to increase the care provided in the medical home, but it needs the support of payment reform in order to do that. The other thing that we're going to do under economics is we have the house staff may not know this, but the faculty know this, is that everything you do is valued in a system called RVUs. It was designed to, quote, equalize the playing field. So if you were an ER doc and you spent an hour and a half resuscitating a sick child, and you were a pediatrician in your office and you saw 7 urgent care visits, you spent about the same time. The complexity may have been a little higher in the ER, but the volume was higher here. And it was a way to try and equalize the playing field. It doesn't equalize the playing field for peds. The procedure-oriented disciplines are valued much higher in this RVU system. So we're going to take that on. We don't know that we would change the RVUs, but we're learning different strategies to help us think through, maybe it's not changing the system, but changing how the system is built and some of the ways that this has gone in this. If you had told me 10 years ago a workforce initiative would address claims denials, I would have said you're nuts. But I guess all of you get your reports about sign your charts, you didn't add this diagnosis, or have you completed this, and you get your denial report. These denials, especially for services like EPSDT, which is the early periodic screening that happens in primary care, are different from state to state. It's unconscionable. We're going to fix that. That is not something that we can continue to let to happen. And the other is redesigning the pediatric subspecialty loan repayment. Now, as an aside, for all of the trainees, we were talking about loan repayment. This is a loan repayment that is for more rural areas and underserved areas. But there's an NIH loan repayment program. And I'm not going to reveal the name of who told me this, but that it's not applied for as commonly as it should be here. So every trainee in 2 years, when you are getting ready to enter your research fellowship part, if you're doing a subspecialty, it's research focused. So if you're not doing research, you're not eligible. Should apply for the NIH pediatric loan repayment. It's up to, I think, $50,000 a year now of loan repayment. And for a number of years, the success rate was 50%. So that's just the added benefit of the talk today. Okay, what are we going to do in medical education? So Becky is going to do the following. We're going to increase exposure to peds at a much earlier point. And here's Allison. Where are you, Allison Guerin? Okay, so I learned about the PIPS program yesterday, which is a phenomenal success story. For those of you who don't know the PIPS program, I've learned a lot in the last 24 hours, but it takes students who are underrepresented in society at an early point in high school and educates them about pathways to college and to medicine. You've got to track down this lady and you have to hear about PIPS. We've got to disseminate PIPS. So that's another thing that I've learned here, that we're probably each doing things that we're not sure others are doing. And we should share this. Like we talked yesterday, we think there's another model. I think Wade Clapp in Indiana has a similar model. It's 120 students, right? Yeah, see, I remembered, Allison, yeah, okay. We talked already that we need flexibility in training pathways. You know, this traditional, you do 3 years and you do 3 years of fellowship unless you're in one of the Board of Peds approved training programs. We're going to change that. We need to think about innovative models. This idea of training you to be an expert in a discipline coming out of residency is something that we should think about. We do that in developmental peds. Now we have a grant for this where each year we take 1 or 2 of our general pediatricians, we buy out their clinical time, which is always the burden, right? Because you're under enormous financial pressure. And we put them in developmental peds for a year. And they learn a skill, autism, ADHD. Then they go back to the practice and they do that embedded within the general peds practice. Probably do need more flexibility in training. And some of the models, you know, should we have 2-year fellowships? That was your debate last year, right? Yeah. Which side won? 2-year, really? Wow. I'm not convinced it's the answer. but I don't know. I mean, but we're only going to know if we try these things. So that's the other message, that we're going to try these things. And we talked with the fellowship group yesterday, Dr. Gans and I, about doing something innovative here, making a model for a 5-year program, presenting it to the Board of Peds. So we're gonna do that. We've been very MD focused. The NRMP for years has been MD focused, and both graduates of osteopathic schools and international medical grads have not been supported as deeply as they should be in Peds. And we don't partner with these groups in an organized way. And we're working on that, including some of the restrictions on international medical grads. Now, Sally Permar, who's leading the physician scientist group, this is a small part of our workforce, but a monumentally important part of our workforce. That slide on why invest in Peds, I truncated a little bit, but we could put together 50 slides on discoveries that have happened by physician scientists. And when we say physician scientists, actually, Dr. Kornfeld and I had a very early breakfast this morning, and he was telling me about an MD-driven program here to build scientists for those who have entered their career as an MD. We traditionally, when we say physician scientists, everyone says, oh, MD, PhDs. That's not the answer. There are incredible MD, PhD programs. Stanford has one, their MSTP program. But some of our best scientists are MD scientists. We've got to rebuild, we've got to build these programs out. And it was a phenomenal conversation that we're going to follow up, because I think there's a message here for other departments. And I shouldn't put him on the spot. It didn't take a ton of funding, right? He was able to, I think he's now got about 1.2 million and he's got to do 10 or 12 fellows a year. And it's a rigorous 2-year program. So we're going to do that. And I think the other thing is we need more access to these MSTP programs so that we really think about pediatrics. The other is practice models. We've talked a little bit about this, so you can see it on the slide in front of you. There are a lot of practice models that we need to think differently about, whether it's an embedded subspecialist, whether it's getting back to e-consult, telehealth. You know, how do we solve some of the access issues? We can create that change. We're not yet creating that change, but we're going to come to that. The other is promoting collaboration with behavioral health. So one of your faculty said to your programs director, we should have a PEDS psych program. And Carrie said, well, we actually have a PEDS psych program. So we're all set. You have other ideas. We should be doing more of that. We should be thinking about how do we respond quicker to the societal needs of our families and of the children that we serve. I would say the other thing that I've recognized too slowly is this. I think we've done a pretty good job of educating the academic community. I think. I'm a little biased because I'm one of the group of people leading this initiative. I think it's fair to say we've done a lousy job educating the public. And this was a theme we had at this dinner conversation last night, is we've got to break away from the messaging in academic PEDS and think about how you make changes in a society. When you think about examples of what you've seen, Mothers Against Drug Driving, who's familiar with that group? Okay. The anti-vaxxers, who's familiar with that nutty group? Yeah. They each started with how many people? Yeah, they each started with one person or 2 or 3 people. And they figured out creatively a way to change the public's perception of, sadly for a long time, vaccines, but also drunk drivers. We're going to work on what that is for pediatrics. I don't know what that is today, but after dinner last night, I'm convinced that in the next 6 months, we need to think about that. So in 6 months, Dr. Leonard and Dr. Blankenberg are going to report out on what this message is. The other is we can't forget about the diversification of the workforce. We have not been successful in medicine. Now, we in faculty blame it on residencies, saying that residencies aren't recruiting diverse candidates, then residencies blame it on med schools. We all share this burden, right? And that's why the summit that Dr. Blankenberg led and actually has now written about is a powerful way to think about how we can continue to support the diversification of our workforce in all of the important ways that we should be diversifying. So we're partnering with many of the organizations that are also thinking about this, but we've got to row in the same direction. The trouble with academic medicine is we tend to work in parallel with each other. And I think the beauty of what Becky was able to do in the summit was to get a group really thinking about how we rowed together. So what's missing? So what's missing are a couple of things. Like, this was much about data, much about the science of what's happening to the workforce, a little bit about NASM. We've talked about our goals. The messaging is wrong. Just one day here has really convinced me that the messaging needs to change. We need to come back to, we talked about this last night, the joy of peds. You're on, right? There is so much special work that happens in this community and in every other pediatric community. We need to figure out how we package that. We need to build a stronger coalition. We have to stop getting everyone to row in a slightly different direction and figure out how we row together. We also need to give a stronger and consistent message. That PD endo person who responded to the student and student doctor network said, you don't do peds unless you really love it, could have made a much more important message about what we accomplish in peds. And I think that's really one of the take-home messages is we're going to shift the way we think about this. Yes, the economics are important, but there's a message here that we need to develop, that we need to do in partnership outside of the academic community. I misquoted Paul, so I apologize for this, but Paul gave me right back. And I thought this is what the theme was. Don't make the same arguments differently. It's don't take the same, Paul, stand up and tell it what it was.
You got the gist.
Don't take the same data and make it better. Argue it differently.
Well, basically, don't try to argue the facts better. Argue them differently.
We need to do that. I need to do that because we've argued, I think, better, but we have not argued them differently, Paul. And I think this is where the joy of peds comes in. I think this is where the community of what everyone is doing here comes in. So here's our first attempt at doing that. Anybody know Suffs the musical? First of all, you have to know Sally Permar, who's one of our colleagues at Cornell, who Mary and I describe her as a force of nature. So Suffs is a musical. It's about the women's suffrage movement. It's a spectacular musical. It's won a couple Tony Awards. Sally was standing outside the theater exit, and who comes out but one of the stars? She engages in a conversation. If you have ever a conversation with Sally, you're basically told what you need to do. And on October 29th, we're having a special showing of SUFs on Broadway in support of Pediatrics and the Workforce Initiative. It's going to be the kickoff to what we hope will be a more significant change in the way that we look at pediatrics. And I know it's impossible for people from the West Coast to get there. So I'm going to stop. These are the 4 grandkids that Becky pointed out. This is why we do this work very much. And I'm so grateful for the time to be here. Thoughts, comments? Well, let's tear this apart. What do we need to do differently? Trainees, come on, now's your time. Up to the mic.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.